Oh,
All right. The time is 1:01 p.m.
all righty. Good afternoon, everyone. And I would like to call the meeting to order. And a quorum is present. And I'd like to remind everyone, as always, that we are streaming via YouTube. So just a heads up on that. First item on our agenda is the approval of minutes. And I'd like to ask for a motion to approve the minutes of the December 10th, 2025 meeting of the Population and Community Health Committee as presented. Give
So
you a
moved.
minute to look. Okay, so move. So do I have a second?
Second.
All in favor? Aye.
Aye.
Any opposed? Any abstentions? Hearing none, motion passes. Thank you. Next, we will be moving. We have a number of topics that have been prepared by the team, and we're going to start with an overview of priority measures for 2026, which is presented by Mr. Matt Hoffman. Thank you.
Thank you so much. And I just want to be sure everybody can see the screen. Okay, wonderful. And so I will be driving today. So all subsequent presenters, unfortunately, will be like, go ahead and advance. So we'll be dealing with that through that. But thank you for this opportunity. So just to jump right into the focus that we wanted to start with, we wanted to give an overview or review of some of those priority measures that we had started to talk about at our last board meeting, and really helping us to identify what areas do we want to focus on in 2026 when we think about our population and community health objectives. And so there were four primary measures that we had gone over. And the first is diabetes, and we'll get into each of these in a little bit more detail. But diabetes, and this is specifically looking at HbA1c or glycemic status assessment, and for those patients that are sitting greater than 9. We want to look at the second chronic condition of controlling hypertension or controlling high blood pressure. A newer one for us is the 7-day follow-up for all substance use disorders for ED patients. And then finally, preterm birth, which will be the major focus of our presentation today. So first, to talk a little bit about glycemic status assessment. This is a little bit different measure than the others in that this one is an inverted measure. So we want to see a lower percentage as this one goes throughout the day, or throughout the year, excuse me, where we want to see that someone's A1C is not greater than 9. So it's kind of an odd metric when you look at it that we want to see people less than 9. So this metric really looks at patients between 18 and 75 years of age with diabetes who have an A1C greater than 9 or did not have a test at all. So they would fail this metric if they did not have an A1C test. So there's two kind of factors that we need to look at when we talk about improving performance on this. First, getting them in to get it measured, and then the second is to make sure that we're doing everything we can to lower those that are higher. And as you may recall, we did have an index of disparity measure that was created to help us get some insight as to where do we see some of these disparities within our different populations. And so I've highlighted some of those for you here, just as we see, you'll see some significant, or I should say consistent variability here with these measures. The age group is 18 to 35 and 35 to 55-year-olds, and that might be a little counterintuitive to where you think of with diabetics with issues here. The Medicaid and self-pay, which you're going to see that consistently through a lot of our groups. People who are Spanish-speaking or Hispanic from a language and ethnicity perspective, and then anyone who's Black or African-American tend to have worse performance on this metric. We do have a lot of system interventions that we're working on with this, and one of those is what we call point of care testing. This makes it a lot easier for patients to get that A1C right at the site of care, not having to go to a lab and waiting for results. So it really makes it easier on the patient and also easier on the provider to get that information to them right in the visit and let them react and work with the patient for that. The pharmacy department is really working on initiating a great program and where they're going to help the primary care teams and support them in managing patients with high A1C. So really giving that extra blanket of coverage for those patients that need assistance with this. We're continuing to push more continuous glucose monitoring and continuing to try to expand this in all of our patients and getting them access to these monitors to help them keep really tight control of those their glucose. And then also looking at expanding our nutrition department implementation of diabetes self-management education courses, or DSME. With controlling hypertension, this metric really focuses on the 18 to 85-year-olds who have a diagnosis of hypertension and whose blood pressure needs to be adequately controlled. Our index of disparity, again, you're seeing some consistency here, but with those Medicaid and Black African American patients, they tend to have higher incidence of this. And so starting to show where we need to start focusing some of our energies. We do have some new BPAs or OPAs as they're called, and these are different things within Epic to help drive clinical workflows to help treat some hypertension and allow people to get the treatments they need. And then we're doing a lot of outreach through automated systems through Epic, which we call Cheers campaigns. And this is keeping communication with patients and letting them know we really want to see them for their follow-ups, because we have all sorts of different interventions when it comes to nursing interventions for follow-ups with hypertension, and then also follow-up visits with the provider to help get that under control. 7-day follow-up for SUD, or substance use disorder. This is a tough metric. This is trying to get the percentage of emergency department patients to be seen within 7 days of a substance use disorder diagnosis in the ED. So we really want to make sure that anybody comes in and gets treatment for substance use is connected to the system after the fact. And that's the focus of this measure. When we talk about addiction and dealing with those services, it's not just a quick throw some medications or a quick counseling with them, but really connecting them to services and making sure they're having the support that they need. We've done a lot of use with this, or a lot of interventions with this. You may have heard a lot about the Office of Opioid Safety has done work with this, and creation of the substance use navigators. We're looking at expanding those programs and continuing to connect them with our behavioral health programs to have a more robust model and more comprehensive type model to support these patients. We also look at this when we talk about substance use. We don't focus just on opioids. We do look at alcohol use disorder and any of those substances. So it's more of a all-encompassing blanket to help treat patients with addiction issues. The one other thing I want to highlight with this, and this is also the same for the preterm birth metric, we are still working at developing the index of disparity for these. Because these are new metrics, we had to first build the core metric itself with an Epic to make sure we meet the definition needs. But then after the fact, we need to build all the elements to help us develop the index of disparity. So we are thinking within about a month or so, we should have that up and running and allow us to see more in depth of what populations are affected by this and help to inform our interventions going forward. So with preterm birth, I will simply say that the percentage of members, this metric is the percentage of members that have a delivery before 37 weeks. I won't get into a lot of the interventions because I don't want to steal the thunder of everybody else that's going to be coming after me, but they'll help to highlight all the programs across our 4 pillars that we look at with preterm birth. The final thing I wanted to bring in front of everybody is this graph. Frequently in some of our other boards, we look at our data every meeting. We wanted to keep that same theme here. We wanted you to be able to see how we perform on these metrics as a system and bring this up every month. So we created this table to see how these metrics are performing month after month and allow us to see any progress that we've made. As we go through subsequent meetings with this board, we will have more in-depth program, or I should say intervention specific metrics that are helping to influence these overalls, but we wanted you to always have the overall picture of how these metrics are moving as a system. So with that, does anybody have any questions on those 4 metrics? Yes, Dr. Walker.
Sorry, I had to cut the audio on. Just want to make sure I assume you are, but you are coordinating with quality on these metrics. I know you've taken a slice out looking at a group here that's particularly having issues, which is important, but I just want to make sure that this is done in coordination with quality, correct?
Absolutely. I work with Dr.
It's all
Golub on
the
a lot of
same.
this. Yep.
It's all the same.
Okay, thank
Same
you.
team. It's the same team.
Thank you.
Yep. Thank you.
Matt, I know that we're going to get into more detail later, but one question I have is that I understand that, and I appreciate that we are data-driven and we're research-driven. But there's also that extra special sauce in this type of work where we really do need to know the community, know the audience, and be able to speak directly to that audience, that community in a way that they can hear it. And so when we talked about navigators, we in the Latino community, promotoras, I had a great conversation just yesterday with a Black pastor about these are the people that are trusted and can be our translators, our bridge to the community. So I'd always, and I think maybe Ramona is probably going to get into this later, but what is our strategies? Because these are critical for interventions to work in specific communities. What's our relationships, our strategies, and making sure we have we're connecting to the right individuals that are trusted and can be our bridge to really being able to educate and work with specific groups.
Absolutely. And I think sometimes when we do look at this from the data perspective, it does seem so focused on what are the direct clinical interventions that we're doing. And I think while those are important, the engagement with the community and how we're engaging with all the members of the community and our patients is absolutely critical to do this. And when we look at some of those other pillars, like Karen Cook's pillar, when we talk about health-related social needs and social drivers of health, that will help to influence. And then absolutely, when Ramona talks about some of the things, how are we engaging with the community? And, you know, the interventions we may decide on or think that are a good idea, we need to present those to the community and goes, does this work for you? Does this make sense? And that's absolutely part of everything that we need to do with this group.
Correct,
And
because
it
at the end
is,
of the day, we want to really change and reach those health outcomes, and there's different ways that we have to make sure that we're reaching the community. I'm sorry, Dr. Chiara?
no, absolutely. That's the bridge between what Dr. Walker is saying and what you, Nancy, are saying. If it was just about this dashboard, what you're just seeing here, we won't have this committee. This would be purely in the quality. And the bridge between what is done in quality and what is done in this community is to really emphasize that those outcomes, you cannot reach them without specific intervention that goes beyond the clinical, traditional clinical, which is how do you deal with the social determinant of health? And that's one of the pillars. How do you deal with your community? Another one of the pillars. And the third pillar is how do you work with your workforce to understand those nuances that will influence the patient to change their behavior. And that's exactly how this committee differs from a standard quality committee, because we really want to emphasize those type of interventions, but not dissociate them from the true quality work.
Thank you, Dr. Shahadi. You hit right to the point. That's what I was getting at.
Yep.
Mr. Minor?
Yes, thank you so much. I just wanted to say very briefly that we are about to implement a phase 2 of Project Thrive, where we set up these care teams in churches and we train care ambassadors. I would love to be able to, this is good data, good helpful information. I would love to find a way, we worked with Karen before, of how we can turn these care ambassadors to do some follow-ups. I think that person-to-person encouragement, trusted community members, but certainly there's that barrier, there's that challenge of, how do we use community persons to do follow-up directly with our patients. So that's a huge challenge. But I think this really fits. I think they have done trauma before, but certainly chronic illnesses fall under trauma as well. So I think we have a great opportunity to find a way to make this work, because this is so very important, especially around diabetes, self-management, all of those issues. I think the healing, we've said this over the years, that the healing starts in the hospital, but it really ends in the community. And that's where we have to.
Thank you for that, and thank you for the conversation, because I have heard some questions in the community. Did we walk away from some of our work? No, we doubled down on it. But it's data focused, it's research based, but we are continuing to build upon the relationships and the collaboration and partnerships that we have built over the decades with our community. So thank you for that, and thank you, Matt. So this is going to be a really great piece where we're going to zoom in on one of our areas of focus, which is preterm birth. And we're going to look at it through the lens of all of the 4 pillars, starting with Ms. Cazell, who will discuss the quality and performance overview. So thank you, Dr. Cazell.
Thank you. Thanks, Matthew, for the slides. Just a quick definition again. We're looking for, when we talk about preterm birth, it's babies born early, which is before 37 weeks in a pregnancy. And currently, our national rate is dependent on data from 2022 CDC. We are around 10.4%, although it was higher before it went down in 2022. When we look at the at local level, this infographic that you see is from the City of Cleveland Public Health Department, and locally we are around 15.6%. They have included this in infant mortality rate also because it does affect it tremendously. Next slide, Matt. We built this dashboard for preterm birth at Metro Health. That was at the end of last year when we started looking at the measure, and we went back to 2024 up to this year. As you can see, 2024 we were at 11%, 25 10.6, and in 2026 we were at 7.7% so far. This rate could go up depending, again, this is dependent on deliveries on a monthly basis and when they delivered. So this rate might go up, yet we are lower than the local Cleveland rate of 15.6. And then for this measure also, we will be building index of disparity too. It is important to talk a little bit about the etiology of preterm birth and why we can never be at 0% with this measure. Because there is 2 types of preterm birth. They're classified as spontaneous and indicated. So sometimes we have to deliver a baby early. And the reasons are listed here. We're going to go over that. Preterm birth due to preterm labor, for example, cervical dilation or rupture of membrane, this is classified as spontaneous. And labor that is induced with infant delivered, for example, by either C-section or the induction itself, they are indicated. From also research and looking nationally, it looks like 2/3 of preterm births are spontaneous, and then 1/3 would be medically indicated. This is from data, again, from 2008. And when we look at risk factors for indicated specifically, preeclampsia is one, diabetes, complications, intrauterine abnormalities, and placental abnormalities could be reasons why we have to deliver medically indicated preterm birth. And in general, for when we look at risk factors or maternal risk factors for both, whether spontaneous or indicated, older maternal age comes there, heart disease, hypertension, diabetes. So all of these chronic illnesses, previous preterm delivery is also, it is a big risk factor for, again, future preterm birth, as well as socioeconomic factors. So that's why a group at Metro Health, we have already 2-3 meetings with OBGYN and primary care. And based on all of this information and feedback from our clinicians, the focus for 2026 is going to be around risk factors even before pregnancy. So next slide, please. So we will be targeting women of childbearing age. But before I go into that, I want to discuss what work has been done already at Metro Health for preterm birth. The most important thing is our timely and frequent prenatal care that we have been working on for years. And prenatal care is a crucial part of preventing preterm birth, especially if it is within the 9 to 12 weeks, the first 9 to 12 weeks, which is around the first trimester in a pregnancy. That not only prevents preterm birth, but also it improves neonatal outcomes. So some of the things that we have been doing for years since at least since I've been involved, 2019, are consistent completion of pregnancy risk assessment forms, gathering information about mom's risks. And this is actually a requirement from Medicaid to all our pregnant women. And it is also, we are measured. It's a measure that we have to report to Medicaid. Completing nurse visits via telehealth. This is important too, because we are trying to get anybody who's pregnant a very early appointment with a nurse to go over education, to go over those risk factors and collect them and prepare the mom for the first prenatal visit and even schedule that visit as soon as possible. Same thing we are doing in express care, and hopefully soon getting that into the ED, is when we get a patient who we find that have a positive pregnancy test, we want to immediately schedule that patient in an appointment with prenatal care before they leave express care, before they leave the ED. And involving community health workers, we have been doing that prenatally and also postpartum after delivery. Our community health workers, they do provide lots of outreach to patients. They support them. They go with them to appointments. They complete social determinants of health, and also provide support and anything the mom needs for that baby and for herself is being coordinated by the community health workers. And then implementing universal aspirin protocol at Metro Health. That is started, I believe, at the end of last year. And the importance of it is that it is preventive. It is a low-dose aspirin of 81 milligrams for preventing or preeclampsia prevention, and it is to patients or women at 12 weeks and over if they don't have any contraindications. And the last thing is, and I believe probably Ramon is going to talk about this a little bit more, we do have a local collaborative with First Year Cleveland. It's an initiative with lots of organizations in the community to also work on this important measure and to come up with interventions that we all will apply. What do we need? Oh, we still have one. I just wanted actually to highlight, you can go to the graph. Okay. I did want to highlight the prenatal care, that's measured, the timeliness of prenatal care and getting moms within that first trimester. I wanted to highlight all what I've talked about in a graph to say this is the work that we have done so far from 2019 to 2025, moved from 69 to 82%. Go ahead, Matt. What do we need to do? So like I said, we already as a group looked at risk factors, looked at what we have, our clinicians are suggesting and looking at best practices, and definitely taking care of our childbearing women. Again, 18 to 45 is something that we said we want to expand it as much as we can, is who we are going to take care of and start looking into, preventing that preterm even before pregnancy. So the first and most important thing and initiative that needs to happen is screening for pregnancy. If somebody's coming in, we want to ask them if they are in that age group, are you planning on getting pregnant? As simple as that. And based on that, referring them to preconception counseling. So this is a workflow that we need to ask and put in place at this point. The second one is addressing uncontrolled chronic illnesses for our childbearing women. Again, focusing on diabetes and hypertension, making sure that they are controlled. And that work is not only in OB, this is definitely in primary care And we do have a pharmacy also part of that team, and it will be in collaboration with the pharmacy. And then the last one is addressing continuity of care for women with previous preterm birth. This is important because they are a very high risk also for future pregnancy. So, now we do follow, we make sure that they are coming back after delivery for a postpartum visit within 84 days. And we want to expand this follow-up and this continuity of care and go beyond that. And part of this work or this intervention here is to educate on spanning pregnancy too. This is important, and that will be implemented part of that. Next slide, Matt. So the last thing I just want to say is, like Matt said, we will be presenting data and follow up when we come back in general on what we are doing and how this is progressing. So it's not only the rate that we're going to look at how we're doing with aspirin administration compliance. It will be important for us to look at, the spontaneous versus indicated at Metro Health. What is the ratio that we have? Because that will also, if spontaneous is 2/3 of the 10% that we're talking nationally, this means nobody can go beyond 6%. If we're talking about those percentages and ratios. It's important to look also of having a registry for preterm birth so that we can follow up with these patients. And like I said, index of disparity will be coming, and you will be seeing that in the next meeting or next presentation. Any questions?
Hearing no questions, or did I hear one? Okay, we're gonna move on. Thank you, Ms. Cazal. Next, Ms. Cook will discuss preterm birth metrics through the lens of our next pillar, barriers to health.
Great, thank you very much. I appreciate the opportunity to speak with the committee today. And what I'll be sharing with you is some of the results and insights from our social drivers of health screening, particular to the OB population. I'll also be providing a brief highlight of some data analysis that's been done on factors that impact the timeliness of prenatal care metric that Nasreen mentioned. A brief highlight of a literature review of STOH as it relates to preterm birth. And then I'll move into highlighting some of the current programs happening within our Institute for Hope relative to this population and this metric, as well as some opportunities that we're looking into. So starting with the STOH data, this slide is showing you just the screening rates for a sampling of the domains that we screen for. It's a little bit small, so I will share with you that looking at the colors starting from the left, that deep blue is all patients. To the right of that, the purple color is females of childbearing age. And this is looking at encounters in 2025. The fuchsia color is patients who were pregnant in 2025 and seen at Metro Health. And then the lavender color is patients who gave birth in 2025 at Metro Health. And what we're looking at here are screening rates. So it's the percentage of those patients in each of those groups that responded to the particular domain questions. So food insecurity, transportation, et cetera. So what you see is that patients who were pregnant or gave birth at Metro Health in 2025 really have much higher rates of STOH screening than our overall patient population. And part of this is due to the fact that they have a number of different touch points across the system in short succession. And then you see the highest rates for those patients who gave birth, and that's likely also then reflecting the fact that last year, we put in place a fairly robust STOH screening process within the inpatient setting. So many of those patients are being screened when they are hospitalized and giving birth. Why are these rates important? They're really important because this screening is often the first step towards connecting with the patient to work with them to address their health-related social needs. So as part of the screening process, a patient can request assistance, and also certain risks may route automatically to a community health worker or a social worker to engage with that patient and provide follow-up support. So this is really a critical step in our overall pathway to address health-related social needs. Next slide, Matt. So this slide is sharing with you, for those same population groups, same colors, what their level of risk is in these various domains that are being featured. So again, you can see that patients of childbearing age overall, pregnant patients, and those who gave birth at Metro Health in 2025 generally, across most of these domains have higher risk rates than our general population. And we can move on to the next one. This is an attempt to think about our patients who gave birth at Metro Health in 2025. So thinking about the target population in terms of risk for preterm birth, but cross-cutting across the other metrics and conditions that are important to this committee and what we're looking at. So this chart is comparing all patients who gave birth in 2025. So now that's the dark blue, with a subset of those patients who are on the diabetes registry. So they may be addressed by another metric, also monitored by this committee. That's the purple bar. The lavender bar is those who are on the hypertension registry. And then the fuchsia color is those who are on the substance use disorder registry. So again, you can see as we slice and dice this data a little bit, we see different levels of risk across different cohorts within that group of patients who are giving birth at Metro Health. And the next one, which I believe is our final one of these SDOH graphs, this one is relating back to what we have seen in the index of disparity, where language is highlighted as one of the top areas where we see disparities in the metric of timeliness of prenatal care. So this one is looking at all patients who gave birth at Metro Health, again, in 2025, that blue bar. But if we look at the subset of patients who indicate their primary language is Spanish, we can see that their risks on pretty much all of those measures, except for intimate partner violence, is higher than what we see for the total group of patients who gave birth at Metro Health. So this is really consistent with what we're seeing in that index of disparity, and really highlights an area that we think we can identify and work to tailor some interventions and support for these patients. I'm going to shift a little bit now to talk about some data analysis that was done by Yusra Adi, who's a member of our population health data and analytics team. This was conducted last year, and again relates to the metric of timeliness of prenatal care. So obviously not the preterm birth metric, but one that, as Nisreen highlighted, is really very important when it comes to healthy birth outcomes. So this analysis looked at those items that were predictors of the completion of a prenatal care appointment. So specifically the metrics looking at the percentage of deliveries in which a woman had a prenatal care visit in the first trimester. And then the goal of this study was to run a multivariate logistic regression analysis to identify what data elements are statistically associated with an unsuccessful completion of this metric. So essentially, who is not showing up for that prenatal care appointment starting in the first trimester. USERA looked at a wide range of data elements, including demographic factors, use of primary care at Metro Health, OB history, social factors, and other things. I have two slides on this study, this one and the next one, and I will just say that lots of really complicated things happen between these two slides. And so what I'm sharing with you now is just a very simple distillation of the results, but we'd be happy to, share more of the full aspect of this work for anyone who might be interested. But what you're looking at here is the distillation of the findings of those factors that were determined to have the most meaningful impact on whether this metric was achieved or not. I will highlight that no-show rate is starred and underlined because it's a little bit of a unique situation. This is referencing the finding that for those patients who had a history of no-show to primary care appointments, it was essentially a perfect indicator of a no-show to prenatal care. So that was a standout finding there, nearly 100%. Then you can see that the other factors, the top 4 on that list were statistically significant, but every factor there was determined as highly meaningful to the achievement or lack of achievement of that outcome. So transportation, number of children, primary care history at Metro Health, financial resource strain, and food insecurity. The next slide is a literature review of very much summarized, but a literature review conducted by Dr. Ash Sehgal, who serves as Director of Research and Evaluation with the Institute for Hope. And on the left, you will find those sociodemographic factors that he identified in the literature that were associated with preterm birth. And so many of these are things that Nisreen highlighted in her presentation as well. So we are seeing consistency there, and certainly some of these are demographic factors. You see some that are factors of place, exposure to air pollution, for example. You see some behavioral factors, smoking, alcohol use, and then other social factors related to food, access, nutrition, stress, and social support. Then on the right are a few suggested areas to think about for interventions to address some of these factors. What I'm going to move into now is just an overview of current programs within the Institute for Hope that are serving an OB population. So I mentioned our social drivers of health screening. So that screener is made available to patients through MyChart 30 days in advance of a primary care appointment, and that includes OB appointments. So many of our patients are receiving the screener that way. If they request assistance, if they have a personal safety need, they'll be routed directly to a care team member for follow-up. Below that, you'll see Unite Ohio. This is our electronic resource and referral network that many of our care providers at Metro Health use. Care coordinators, social workers, community health workers have access to this tool right from the Epic electronic health record, whereby they can make direct referrals to a number of community-based organizations who would then outreach and engage with our patients to meet whatever social needs they may have. So that is a tool that's in place and available to our staff. We have a small lead-safe housing initiative where patients are being screened for potentially unsafe housing conditions when they show up to a prenatal appointment. If they are potentially at risk, they can receive follow-up in terms of a home inspection. And then based on the results of that inspection, we have availability for some other interventions that can improve the conditions of the home, or do a lead-safe clean, or do some basic remediations that may be helpful in creating an environment that is more lead safe before a newborn is even sent into the environment. Below that, you'll see our Opportunity Center at our Buckeye Health Center. So this is led by Marilee Santiago on our team at the Institute for Hope. And this is a center where there is very active social service engagement on site at the Buckeye Health Center. So we have a monthly mobile pantry. There's a resource closet that provides basic needs supports to patients who may be in need. There's an active financial coaching program there for patients who have challenges with finances and want to reach some financial goals. And we have a number of community-based organizations that have shared space with us in the Buckeye Health Center and are able to directly serve our patients there. Moving up to the upper right, our community advocacy program is a medical legal partnership that's been in place for about 23 years now with the Legal Aid Society of Cleveland, where we have attorneys that are embedded at Metro Health locations who can address the civil legal issues that may impact a patient's health. So in 2024, we did receive funding from Ohio's Division of Children and Youth to ensure that this service was expanded to serve patients who are pregnant or newly parenting. So that funding was just renewed, and we will have access to that funding through June of 2027. So that's been a very active initiative, particularly with an OB population. We also, as you notice, food insecurity is an issue that impacts this population. We do have 2 food as medicine clinics. These provide a nutrition intervention for patients who are food insecure and have chronic conditions impacted by diet. So predominantly hypertension and diabetes. So as we move into those metrics specifically, you'll be hearing a lot more about this program, but it is one that is open and available for our patients who are pregnant to access if they meet those eligibility criteria. And then under our Food as Medicine umbrella, we are participating with Case Western Reserve University and the Greater Cleveland Food Bank in an NIH-funded study called Nourishing Tomorrow, which specifically is providing medical tailored groceries to patients who are pregnant and food insecure. So that operates out of our Food as Medicine clinic. And then we have various other smaller activities and touch points through our department. We have a representation on First Year Cleveland's Housing Committee. So we know that this is a critical issue for our patients and want to really engage with any community initiatives that may be addressing that particular need. We have just developed SDOH resource guides that can really support all of our staff in navigating some of the social needs that our patients face, and we'll make sure that those are available to our OB teams. We have additional mobile pantries. We have a very small patient assistance fund that can address one-time basic needs, many of those related to housing. So we have, as you can see, a fairly robust set of services, many of which are either directed to or available to the particular patients that we're focused on today.
Karen, I have a question. Going back to slide 26, we that metric that looked at language as a barrier, I was surprised. I'm sorry, it would be 25, I think. That one.
There it is.
Okay.
Yep.
Yeah. Is this just primarily Spanish, or are we looking at, because now we have a very, very robust immigrant population? I'm assuming it's many different languages, but
Yep.
okay.
Yeah, so the tall purple bar is Spanish.
Okay.
And the lavender bar is language other than English or Spanish. So it's more of a catch-all versus being divided out by a specific language in this case.
So my question is, seeing such high numbers, specifically with Spanish, I was looking at the programs or interventions that are specific to that issue, which I think you should be able to make a huge impact fairly quickly with staffing, with use of different technology that helps with translation. And so I guess my other question is, it's not just understanding the language. I'm assuming too, it's the culture. And are you looking at any interventions or programs that would target this particular slide issue when it comes to disparity?
Yeah, one particular thing, and this ties back to noticing the risk for financial strain that you see here on this slide, as well as that being highlighted as in the research as one of the particular areas that can make a meaningful impact. We have just hired a bilingual financial coach that will be joining our team at the Opportunity Center, and we're talking through how, what strategy we would use for that staff person to particularly engage with this population that's being reflected in the graph. So patients who are pregnant at Metro Health or women of childbearing age who identify Spanish as their primary language. So really trying to build out that particular service as one example.
Thank you.
Mm-hmm. And this is my final slide, but this is highlighting some things that we believe are opportunities and that we can look at. So the second one there in purple is the one that I just mentioned. And thank you, Kathy. I just saw your note in the chat, and thank you for reminding me of that. But one of the legal aid attorneys that is on our team also is a Spanish speaker. So the first program here is Fresh Connect. So this is thinking about, again, what we've seen in the literature and understanding the need for nutrition resources targeted to this population. We are looking at a program that is essentially a medically tailored grocery card. It's a reloadable prepaid card that can be programmed just for healthy foods to be purchased at local food retailers. This is something that has had a demonstrated impact with some work that ProMedica did, in particular looking at impacts on preterm birth. So we are looking at a pilot for women of childbearing age who have chronic conditions. So based on some of the work that Nisreen featured earlier, is how do we address some of these things in tandem where we know there are issues and where we know there's an ability to make an impact. So that's one that we're actively looking at right now to really shape a pilot. And by having the prepaid card, this really gets at some of the other barriers that we've seen where it may be hard for somebody to access one of our on-site clinics if it's a younger person of childbearing age, or they're working during the day, or they have multiple children, which complicates their transportation access. The prepaid card can be a solution to some of that. So that's something that we'll be looking at. Moving down to the blue area, we are looking closely at our opportunity centers, since those are community-based resources that have multiple services available. We think there's a way that we can really enhance what we're doing there to address an OB population, whether that is expanding our resource closets to make sure that we're having those items that are most needed by pregnant women, whether we identify new partners that we can bring on site to offer their services directly as our patients are engaging with us for appointments. We also have our community space at Viasana, which has been used in the past for community baby showers. We think is amenable to other types of group services. So that's an area that we'll also be looking at, how we tailor it more specifically to this particular metric. As well as our use of Unite Ohio. We know this is a tool that our CHWs and social workers have available to them. We think we can do some refresher training with our staff that are in the OB clinics, and we can also identify other community-based organizations to be part of the network if there are services that's most needed by this population and are not currently represented on the network. And then we will always continue to look at our SDOH screening practices, both to learn from what our screening results are, but also to look at ways that we can really improve the consistency of screening and the depths of screening for particular at-risk populations, so that we can take that first step to capture the data and move them into some of our support programs. So happy to take any questions or comments or points for discussion.
Karen, I just wanted to point out with this, when we look at these types of things, we're always keeping in mind that all of this is not a one size fits all. And just to focus on that Fresh Connect piece that we looked at, we want to look for innovative ways to really implement programs. And sometimes when you have standard food pantry type meals that are prepackaged foods, that doesn't necessarily meet the cultural needs of the individuals who need that type of to have that food. So giving programs that give them some flexibility and some choice to things that would be, more comforting for them to eat, as opposed to here's your just canned, I don't want to say canned, that's not good, but here's your predetermined meals and this is what you must get. Giving people opportunities to have choice and to be able to do things that's more appealing and more friendly for them to do. So we're always looking at things like that when we talk about these programs. What's a new innovative way that we can implement these that are going to be a little bit more, maybe palatable is the term, for everybody who's engaging with those programs.
Any other questions or comments? Okay, thank you, Karen. Next, Ms. Brazil will discuss community engagement, preterm birth metrics.
Thank you. Thank you so much. And thank you to everybody. Glad to be here today. I also just want to echo some of the earlier thoughts and ideas about community engagement and why it's important. A lot of times groups like mine are brought in at the end after things have been decided, and it's, can you distribute this flyer, or can you, go and do this? And yes, is often the answer, but but including it from the beginning, from the design, from the metric, is how I think that we take what are good ideas and we help them become impactful for the people we're trying to reach. So just to kind of start at a 30,000 foot view, there's lots of efforts that are going on in around preterm in our community. There's different groups and collaboratives. And so one of the things that we can look to do is to align our system efforts with what are community health improvement initiatives. And so Karen and I were on a call a little earlier today with both health departments as well as all the health systems as they are looking at their next cycle of their community health needs assessment. And maternal child health is a priority that they have selected. And so, as they look at data, as they look at different interventions, we can look at how what we're doing aligns with these larger efforts. It's the way that Metro Health can contribute to a larger population health initiative, but really in our patient population, understanding that's where we have the most control in what we do, and being able to track data and impact. So that is something that certainly will continuing to go on, and certainly will share with this group as they go through that process. I think we heard, Karen, that maybe the community health implementation plan would be done maybe towards the end of the year for the county and city. Another thing was also mentioned was First Year Cleveland received some funding last year from the state to create a Partners for Change initiative, and part of what they're focused on that is preterm delivery. They did create a healthcare collaborative committee, and it does have all of the health systems as a part of it, as well as neighborhood family practice. And through that, there are some shared interventions, which we talked about with like universal aspirin or remote blood pressure monitoring, early initiation into prenatal care that have been selected for all of these systems to be working on this in their own system and collaboratively, sharing on quality improvement efforts. What are some best practices folks have found? I can say we had a meeting about maybe a week or two ago, and Dr. Gibson presented on some of our remote blood pressure monitoring efforts, and we are as a system maybe more ahead of where some of the other systems are in their work on blood pressure monitoring. So, but to hear kind of where folks are and how they're implementing it is helpful to understand what's going on in the community. Then they are also have a Queens Village Community Engagement Initiative. So they have a group of women working through Neighborhood Leadership Institute, where they have come together. They've done some focus groups. What are women's experiences in delivering at hospitals, and what were their pregnancy experiences? And some of what we're hearing and seeing in our own patients align with what these community members are saying, which is also kind of reaffirming of our direction and where we're trying to head to. There could also be differences in what maybe a generalized community group might be saying, that receives this care in a variety of places, and specifically what our patient population is saying. And so we also want to understand, where is there differences, and where are there things that are in common. In some ways, we might be doing better than what is the general community sentiment. In some ways, we might have some things to improve on. And then to collaborate on community communication. So as we implement new interventions like universal aspirin therapy, that will be a community education need. Why should folks trust this? They heard, don't take aspirin or Tylenol, during pregnancy, but take aspirin every day. So people will need to understand, even outside of their provider offices, that they aren't being told for the first time about this intervention, and they might already have some hesitation. I think that goes back to Ms. Mendez's point of who are our trusted messengers in the community who can share this information, and in a way that folks hear it and they understand it before it's not just the health system saying it. And then to explore, which also came up, our maternal health partnerships, and to be more intentional about those. We certainly have built relationships with lots of groups, whether it's Burning Beautiful Communities or Village of Healing or Pregnant with Possibilities, or First Year Cleveland. But there's probably ways that we can turn those relationships more into workflows or referral pathways or warm handoffs. But you have to be very intentional on how you approach that and how you do it. And then who are the folks in the community that are trusted, that are extenders of what we are trying to accomplish. So there's essentially this need to make sure Metro Health is connecting up to broader initiatives and out with other community groups. Okay. And the second part is, how are we connecting into the neighborhoods and with patients and community members? So we have to listen, we have to have conversations, and part of what we can do is to partner with our patient experience team. We work together very well, and OBGYN to host some community conversations. And so what we need to hear are people's lived experiences, especially if they've experienced a preterm birth. What would have made it, easier to navigate? Do they have trouble navigating the system? We have a lot of programs and things that we offer. Are they aware of them? Are there ways you get into these programs or get connected to care? Are they obvious to people? So we need to hear from them what that experience is like. Then we can host educational sessions with our Metro Health providers in community settings on key topics that contribute to preterm birth. So if we want to talk about pre-pregnancy health, and we want to talk about blood pressure control, or after you have a baby and your blood pressure was high, these are things that are not maybe just widely known. And so, do folks know, after I delivered and I had gestational diabetes, I'm now at risk for diabetes, even 20 years from now. So, we have to have those conversations in places where people feel comfortable being, whether that's a community center or a church, or with in partnership with some of our groups. And then, as was stated earlier, we need to make sure that we gather input and feedback on our proposed preterm interventions. We might think that these are the things, that we should do. And if we do this, then that equals this. And then you may go and speak to a group and find out, no, that wouldn't actually be that helpful. But if it was done this way, or if we had received it here, that would be. So we have to be very intentional about how we design our interventions, and that the people that we're trying to reach are a part of it along the way, not necessarily just at the end. And those are my slides. So I don't know if there's any thoughts or questions. Certainly we'll turn it over.
Thank you, Ramona. Great information. I want to just go back to a couple. Sorry, I'm hearing a little bit of echo. A couple comments, points that were brought up several times, which is really listening to the community and building interventions and programs along with them are critical. Going back to the example of food and having choice pantries, that all came out of the need for people to actually eat the food. That was the whole point. That's, the need was the people to have nutrition. And if they had bags of food that were culturally not something that they would like to eat or ever ate, then it was a lost, it was an intervention that just wasn't working. And it was really conversations like this, institutions like these, programs like these that really brought out that new way of looking at choice pantry and food that was culturally based. And then you could see the ultimate goal, which is health improvement. So thank you for your work. It really does tie into really reaching our metrics. So thank you for that. And so moving on to our next pillar, Dr. Moreland will discuss patient-centered workforce preterm birth metric.
Thank you so much. My name is Connie Moreland, as you said, and I serve as the Vice President of Provider Pipeline Development and Engagement here at Metro Health. And I just want to thank my former pillar leads for really setting this up nicely for me to do my best to try to tie all this phenomenal information together in terms of how we build a patient-centered workforce, how we here at Metro Health put the patient in the center of care. So I will be discussing a strategic framework for building this patient-centered workforce here at Metro Health. This work is grounded in 3 key focus areas: patient experience, workforce engagement, and health equity. Together, these elements form the foundation for improving outcomes, strengthening trust, and delivering high-quality care. Next slide. Vision and goals. Our vision is to create a culture of compassionate, culturally responsive care. We aim to ensure that every patient feels heard, respected, and supported. We are aligning workforce efforts with system health goals. A key priority is reducing disparities, especially in preterm birth. This is about transforming both experience and outcomes. Next slide, please. Our work is organized around key strategic pillars: patient experience leadership, provider education, cultural competency and empathy training, patient and family advisory councils, customer-friendly culture, employee engagement and recognition. Together, these pillars build a patient-centered workforce. Next slide. Patient experience leadership. Strong outcomes require strong leadership. Patient experience is a system responsibility. We are establishing a patient experience steering committee aligned around our HCAP scores. We integrate metrics into leadership dashboards, and we move from intention to accountability to results. Next slide. Provider education drives outcomes, and so we therefore align education with our system priorities. We focus on reducing preterm births and disparities, and we utilize dashboards to track impact. Education in this context is practical, measurable, and outcome-driven. Next slide. Cultural competency. Care requires, and I think we've all touched base on this today, empathy and understanding. We implement training and communication, bias and trauma-informed care. We use simulation and storytelling, and we focus on culturally responsive care to build trust. Next slide. We include patient and family voices through patient-family advisory councils. These reflect our community and inform care design. They provide direct feedback to leadership. We design care with patients, not just for patients. It's very important. Next slide. Customer-friendly culture. We launch every patient, every encounter. We standardize respectful service behaviors. We use journey mapping and service recovery. We ensure a consistent patient experience. Next slide. Employee engagement and recognition. We know that an engaged workforce delivers better care. We therefore recognize excellence and empower frontline teams. We conduct leadership rounding and listening sessions, and we celebrate compassionate delivery of care. Next slide. Implementation. Of course, we would use a phased approach, governance, education and culture, measurement and expansion, and we expect improved outcomes and engagement. Next slide. These last three slides are meant to give you some idea in terms of how we utilize these principles, particularly to address the OB, or prevention of preterm labor and delivery. Community care. Community care is essential to improving outcomes. I think that's come up several times. We therefore integrate doulas and community health workers. We build trust and extend care beyond the hospital. We recruit from the communities that we serve. Care becomes continuous and relationship-based. Next slide. As an example, group prenatal care. Group prenatal care strengthens outcomes and experiences. Models like Centering Pregnancy promote shared learning. Patients build confidence and reduce isolation. Teams collaborate across disciplines, and care therefore becomes collaborative and connected. And last slide. We utilize risk stratification and targeted support. Risk stratification allows proactive care. We identify high-risk patients early. We provide targeted support and navigation. We improve continuity and reduce missed visits. Care therefore becomes proactive, coordinated, and personalized. And in closing, if we're truly committed to improving outcomes, we must transform the workforce that delivers that care. We already can see, I think, that the future of healthcare here at Metro Health is developing our patient-centered workforce. And thank you very much. Any questions?
Any questions for Dr. Moreland? Dr. Walker?
So how's recruitment going? Are you having any problem finding people to do these tasks?
We have people here at Metro Health. I think that we've shared that we do have community health workers here that are from our community that represent our patients. But yes, we need more. I think we do need more. And we do need to have the support of the institution to go out and recruit more, bring in, so that this work can be enhanced and continued.
I mean, it may be some dual ways to not only advertise that we're doing this kind of stuff, but also using that to attract people who might be interested. I mean, I think we need to let the community know that, as you say, we're still in this business and that we're still trying to relate to them. And maybe, it could be a way of, letting patients know and letting the community know that we're hearing them, and B, attracting people who are interested in this. But
Mr. Summers?
Thank you. These programs all appear to be extraordinarily comprehensive in nature. Do we have enough resources to do all this work? I mean, look for things that might be missing, but it seems like you've thought about all the dimensions and corners and ways to approach it. But and that's just not for you, Connie, but for all the presenters. Do we have? I mean, we have to have some limitations here. Just common sense would say that. But so I asked that as a really some background perspective for me.
I think we have the puzzle, the pieces of the puzzle are in place, but they are scalable. We need more to expand, to do more, of this work. So do we need more resources? Yes, we do.
So Mike, this is we've been at this work pieces and parts for quite a bit of time, and some of that work really even predates me 10 years plus. But it's the cumulative of that work and bringing it together in a meaningful way that is completely different than in the past. So now that we've been on that journey, now we can start studying which intervention, which resources that we put in place, and that we're putting it in a very targeted fashion, because we know that this is potentially where it makes the most impact. This is the Latino lady that is that bracket of age that they have this issue that we're gonna target towards them. Then this is how we can target a population with limited resources. So although it feels a lot, and it is a lot, but we're trying to do all this work so we can target resources to a very specific intervention that's going to have the most impact, so that we're not throwing in a lot of community health worker, a lot of food as medicine program, a lot of things that are like a gunshot all over the place that we cannot afford and nobody can afford. And then you don't get the outcome because you deviated resources from those that are most in need. So yes, it feels a lot and probably is a lot, but it is much, much better use of the resources. That's really what we're trying to get to.
Yeah, thank you for that. And I just as a follow-up, if I may, Nancy, are there really a few partners that are equally focused on these targets as we are, and maybe as energized or resource committed as we are, that we can align with? I think we've mentioned all the community partners, but and I know there are many that are probably striving towards similar goals, but is there one or two that stands out that I'd like to at least keep my eye on as well?
I don't know if you
And I
want to
know
take that,
Ramona,
Connie.
if you want to take that.
Yeah.
But
Yeah.
yes, I'm birthing beautiful communities.
Yeah, Birthing Beautiful for sure.
Awesome group. We don't have our own doulas here at Metro Health, and so they represent a wonderful resource to us to tap into their doula care. And then there's at least one other multicultural group of doulas that speak Spanish, which we're learning about now. We're able to utilize that group. So that is an example. They're building a freestanding birthing center, for example, no competition with us, because their patients primarily are very, very low risk women. A very unique, I guess, group of women will be eligible to deliver there, but that's off into the future. But I would say Birthing Beautiful Communities comes to mind right away in terms of an organization that we can support.
Dr. Alexander, and then Ms. Brazil.
So I think probably I'm going to say some of the similar things. There are organizations that we align with very well, and Birthing Beautiful comes right to the top of mind. And we already have great collaborations with them. Birthing Beautiful Communities helps us do centering pregnancy at the jail, and they provide doulas for our jail patients when they come in labor. So they align really nicely. First Year Cleveland aligns really nicely. I think that those organizations are out there. And I think a little bit to Nabil's point of wanting to know which of these interventions really, makes the most difference for our patients. Some are proven. Centering pregnancy is a proven model of care. It has been demonstrated to decrease preterm birth. And when preterm birth occurs, the babies are delivered at higher weights, which correlates well with survival and less bad outcomes. So just, we know there are some of those models, but we also, what I think we do well as an institution is collaborating. So for instance, the grant that Katie Davis wrote, that we have the community health worker training that happens, partnerships with Tri-C. Those are opportunities for us to bring in folks that can be helpful to our patients. It benefits them because it benefits, for instance, their training program. And then that expands the reach of our team to be able to have these additional folks to assist. So I think, it's a yes and that we want to be really methodical about understanding what works best for different patient populations, then matching the interventions to that, but also looking deeper into the community for where do we partner to kind of leverage those collaborations, because these things are costly. We don't have the finances to, add 100 FTEs for, the doulas and all of the things that we know would be helpful. So how do we leverage the strength of our community collaborations and partnerships? And I think that that's part of the secret sauce that is Metro.
Are we the anchor institution on these metrics, do you think, in this region?
I don't necessarily think so.
Yeah. Go
Um,
ahead.
I mean, all the hospital systems have prioritized maternal child health. I think, and then there's different strengths or priorities that the hospital systems have put on it. But there's been tons of resources where this is a real focus. So I think there's a lot of both political and social will around this topic, and that certainly is helpful as we try and advance it.
And I've seen in a couple issues that have bubbled up where there's community will and collaboration. Lead is another one as an example, where a couple of the major hospital systems have come together along with the nonprofits with a shared goal and metrics, and have really been able to leverage the resources that each institution brings to the table in a environment where we are all struggling with having to monitor the use of our resources. And these are ways where I think as a community, we've been able to come together when we've had these shared goals around issues like lead is another example, and first year Cleveland, doulas, all that is another example. So this is why it's so important that this work is tied to relationships, collaborations, and partnerships with the community, because that's where we're going to bring in additional resources to bear to be able to achieve our goals as well. Ramona, did you had another point you wanted to bring up, or were you able?
Yeah, I certainly agree with a lot on resources and being targeted in what could be most impactful. And I think a lot of our strategies around community engagement will probably, also reflect, well, where should we be, or what population is there of the largest gap, so that we are, kind of wise with our resources. And yes, there's certainly groups that we work with and can deepen our relationship with. And, we have to look at what is mutually beneficial for both Metro as well as a lot of smaller organizations, and finding those shared common goals. And that usually, can lead to something that's more impactful and meaningful for both groups. And then the last thing I just wanted to say was, sometimes it's not always about more resources, and that, please don't quote me on that, because I generally want more resources, or programs. Sometimes it's about integration and coordination and, navigation. And so we should think about that too in this process of, as we think about like our larger strategic plan around access to care and ease of use. What is the journey of the pregnant woman through Metro Health? And, if we literally walk through that, which I think some folks have, so I'm not saying that hadn't happened, but from a positive pregnancy test through delivery, what are these different touch points that she has throughout the system? and where there may be opportunities for either a smoother transition or warmer handoffs, or technology enabled, or Epic integration. So we also have to look at our own system and just how is it operating for people to get through it. So they are connected to all these resources that we have available.
Another piece, Ramona, I completely agree with your statements. I would also add trust, and that's where our community leaders can help us on building that trust, because you could have the best programs and interventions, but if the community isn't trusting the institution or those programs, then they will not be used. So again, all these different interventions and programs and relationship building, we leverage them so that we, again, ultimately, with those shared goals of reaching our health outcomes, it's doable even with less resources. So good questions. Any other questions, comments? Dr. Kaufman, Dr. Chihata in particular?
Just the one thing I wanted to say, when we talk about anchor institutions and things like that, there's a ton of work at the state level too, to really start to coordinate among all health systems. So we have a more unified approach to addressing preterm birth. So there's a development of something called the Impact or Statewide Learning Network with institutions across the state, in which we're really focused on preterm birth as one of the primary things. And I think, when we think about that patient journey, even the variability, not only among the services that are available, but even from system to system and how everybody does things, it's so confusing. And to have more alignment and better flow, or something that's more understandable for moms to be able to do that, is something we're really focused on, and building more consistency for patients across the state. And we're going to learn a lot from all the other institutions across the state.
Yeah, absolutely. So first of all, I want to say thank you for the team. This is really the first of many series to come under the auspice of the Metro Health Board, but transforming this committee into really well-tuned operation is unique. I have not seen this work done that way before. I've not seen it specifically done that way under the auspice of a health system board. So I want to be very grateful for the board to allow us to bring this level of attention to the community at the board level.
Thank you, Dr. Chihata. Any other comments? With there being no further business to come before this committee, the meeting is adjourned. Thank you all, and thank you, team.
Thank you.
Thank you.
38 minutes early.
Always.
That's our new trend.
Just saying. Thanks, everybody.